to my channel Learn OBG with me. If you have not subscribed my channel, please do subscribe my channel, and if you want to learn more about OBG, please go through my channel, and if you have any doubts, you can write it in the comment section, and you have any queries, you can write it in the comment section as well. In this class, we'll learn about the ergot derivatives. In ergot derivatives, we have to particularly remember about the two drugs. One is ergometrin, another is methergin. What is the difference between ergometrin? What is the difference between methergin? Ergometrin is an alkaloid which is actually isolated from a fungus. What is this fungus name called as Claviceps purpura? Okay, so methergin is synthetic product, semi-synthetic product that is derived from the lysergic acid. Remember two things. If it is derived from a fungus, then it is ergometrin derivative. If it is deriving from the lysergic acid, it is a semi-synthetic product, then it is a methergin. But the mechanism of action remains the same, the dosage remains the same, the action remains the same. Okay. So this drugs, they are going to stop the bleeding from the uterine sinuses following the delivery or following the abortion. But you have to make sure that the patient is not having any kind of a cardiac issues or any kind of a hypertensive disorders. It's very important before you give this methergin, you should ask a patient, or you should check the patient about the hypertensive disorders and also the cardiac disorders. Next thing is that the mechanism of action is that it is going to act on the serotonin receptors as well as the alpha adrenergic receptors, and it's going to cause a tetanic uterine contractions. Yeah. Next, what is the dosage that I have to give, doctor? You can give 0.2 mg IM, you can give. Okay, so maximum of 5 doses you can give. You can repeat every 15 minutes, or you can continue every 4th hourly, depends on the situation. Next, it can also be given as a slow IV route and or oral route. Remember, I'm just talking about the ergometrin and methergin. I'm not talking about the sintometrin. Okay, do remember that. So now we'll do the comparison between these drugs. So ergometrin, methergin, sintometrin and syntocin. How they can be used? Remember, ergometrin and methergin can be used orally. Sintometrin can be used only IM route, whereas syntocin can be used in the form of IV fluids and also IM route, but it should not be given in the IV bolus. Ergometrin methergin can be given in IM, oral and IV route. So its action depends on which route you are giving this medicine. In ergometrin, if you are giving in the IV route, it is soon going into the bloodstream, so it will act its action by 45 to 60 seconds. Whereas methergin, within 1.5 minutes, it starts its action. But sintometrin, you are never going to give it as an IV bolus. Sintometrin, remember, there is a metrin, so muscle metrin, remember it as just as an IM route. Okay, if you are giving the ergometrin or methergin, almost if you compare both of them, they are similar. Like, it will take 1 minute ergometrin, it will take 1.5 minutes by IV route, it takes 7 minutes, it will also take 7 minutes oral route, 10 minutes, 10 minutes, but the duration of action is 3 hours, and for sintometrin also it is 3 hours. With syntocin, the duration of action is just for 8 minutes. Used, when is it used? It is used in the active management of the 3rd stage of the labor, particularly not for all cases. If you suspect that there is an atonic uterine bleeding following the delivery or following the abortion, and also the following hydatiform mole. Okay, these are the main conditions where you have to remember. And PPH, what are the causes of PPH? You should remember 4 T's. One is tone, tissue, trauma, thrombi. Okay, you have to exclude all these conditions whenever there is a PPH. And make sure if there is a atonic PPH only, you can give methergine. In trauma case, it is of no use. In case of thrombi, it is of no use. In case of tissue also, it is of no use. We should rule out why there is an atonic bleeding. Is there any tissue, or is there any bleeding pattern disorders are there, or if there is any thrombi that is present in there. And also you should remember about the tissue tear, that is vaginal tear or the cervical tear. Then make sure if there is an atonicity of the uterus, then only you can give the methergine. What are the adverse effects of this methergine or ergometrin? Nausea, vomiting, diarrhea, muscle cramp. See, I said we have to avoid in cases of hypertension and cardiac disorders. Why? Because it is going to cause a tetanic muscle contraction, right? So even the blood vessels will have the smooth muscles in between that. So it's going to cause a vasoconstrictive action, and it will shoot up. So that's why it whatever we are actually precipitating, the conditions like hypertension, myocardial infarction, stroke, and bronchial spasm, gangrene of the toes. So, whatever the peripheral vessels are present, will undergo a vasoconstriction, and it's gonna become a severe, even more severe. So, it's gonna precipitate such conditions. So before giving this medicine, make sure that they are not associated with any kind of a hypertensive disorders or any kind of an cardiac disorders, or previously any history of stroke, or previous any history of bronchial spasm or any gangrene foot and all. And also it will interfere with the lactation. How it's going to interfere? It will reduce the levels of prolactin. So there will be a delay in the milk secretion. You have to remember that. Then when it is contraindicated, I said this conditions where it is precipitating, obviously you have to avoid giving such conditions. So better to avoid in cases of the hypertension, in cases of the heart diseases, and also at the time of seizures and asthma attacks. So if we compare the comparison between the ergot derivatives and oxytocin derivatives, how oxytocin derivatives are going to act, whatever the uterine contractions are happening, we are going to just augment the labor, or we are going to induce the labor. That's it. Okay. But we have to always monitor the uterine contractions and also the fetal heart rate. So it is the law of polarity is going to maintain here. But in case of ergodic derivatives, the law of polarity is completely, it's going to be lost, and it will cause a tetanic uterine contractions. So the mechanism is directly on the uterus, in the myometrium, and also some of the smooth muscles as well, but it will cause very severe constriction. So remember that. And onset of the action for the oxytocin is faster in action, and for in case of ergometrin it is comparatively slow. But when you see in oxytocins, it is within seconds, it's gonna happen. 30 seconds, let's think of. And in ergot derivatives, it will take at least 2 or 3 minutes, right? And duration in case of ergot derivatives, it's gonna it's the duration of action is going to stay longer, that's around 3 hours. But in case of oxytocins, it's not going to stay for a long minute, it will finish off its action within 8 minutes. So the main thing for ergotic derivatives, the clinical uses are, it's gonna stop the atonic PPH, and also it will minimize the blood loss following the delivery, following the abortion, or following the HMON. Then in case of oxytocin, it's gonna induce or it's gonna augment the labor, and it is also used in case of AMTSL criteria. So you have to remember the side effects of each drug, when you should give and when you should not give such things. So as I said, it should be avoided in cases of the hypertension and the cardiac diseases, stroke, asthma, and also the gangrene foot. In case of oxytocin, we have to monitor the uterine contractions as well as the input output chatting is also very important. Whatever I said in the last class, you can go check it out, the oxidative derivatives in the last video. So antidiuretic effect will be present, and there will be a water intoxication is a side effect of this oxytocin. So you should always keep a charting that should be recorded every time, and you should be very careful whenever you are putting this oxytocin and you are raising its dose every time. You should be you should keep it in mind that anytime the uterine may rupture if you don't monitor the uterine contractions, and also about the anginal pain and hypotension as well. Okay, let's discuss about the prostaglandins. Prostaglandins are 20 carbon carboxylic acid with a cyclopentane ring that is derived from the prostanoic acid, which is synthesized from the essential fatty acids arachidonic acid. These are similar like an paracrine or an autocrine hormones. So we know different kinds of the prostaglandins that are present within our body, like prostaglandin F2 alpha, prostaglandin E2, prostacyclins, and all, right? These are actually the inflammatory cells which will actually present at the time of the any kind of an inflammation that is taking place inside our body. So this prostaglandins, they are paracrine and autocrine hormones. So they play a important role in the myometrial contraction, for the contractility and for relaxation, and also for the inflammation. So it will particularly go and act on the G protein coupled receptors on the myometrium and also on the cervix. So the prostaglandin isomerase enzyme and also prostaglandin H2, that is going to convert the prostaglandins. So whatever the prostaglandins that we know is prostaglandin E2, prostaglandin F2 alpha, and prostaglandin I2. Okay. In the late pregnancy, the amnion, the prostaglandin biosynthesis is increasing. Okay. So one thing I will tell in this slide is that main thing that you remember is it is similar to the paracrine and autocrine hormone. It consists of 20 carbons carboxylase acid, and it is synthesized from the essential fatty acids, nothing but arachidonic acid. Okay, in our body, as we have some of the prostaglandins like I2, prostaglandin E2, and prostaglandin F2 alpha, there is also some synthetic products that are going to be produced in the market, which we use it in the pregnancy, after following the pregnancy. So in the late pregnancy, these are actually produced, through which there is, following the increase of this prostaglandin cells inside inside the pregnant lady, there is a signs of labor will be present. And also it will, because of this increased inflammatory cells inside, which it will also increases the amniotic pressure, and also there is a rupture of a membranes, and it will cause the labor induction as well. So prostaglandin E1 and prostaglandin E2, prostaglandin F2 alpha. E1 we can take it as an example like misoprostol, E2, it's a dinoprostone gel. F2 alpha is nothing but your carboprost injections. They are used in a clinical practice. Once again, E1 is a misoprostol, E2 is a dinoprostone gel, F2 alpha is a carboprost, which are used clinically. So the half-life of all these medications in the peripheral circulation is about 1 to 2 minutes. So what it is going to do is it's going to precipitate the labor by prompting the myometrial contractions irrespective of the gestational age. So whereas oxytocin acts as a predominantly over the uterus at the term or in the labor, but this mostly that depends on the duration of the gestation and when to act, which prostaglandin to act, everything it depends. So from where this prostaglandins within our body it is going to produces, the residue as the main source. So in between the, have you heard about the stripping? So whenever, what is stripping, you are actually separating the fetal membranes from the maternal attachment, right? So at this time you are also causing the increase of the inflammatory cells like prostaglandins, and this is going to cause the increase the labor. So prostaglandin E2 for cervical ripening or induction. What did I say for prostaglandin E2? Nothing but dinoprostone gel. So it is available in the form of a vaginal tablets. It is also present in the form of a vaginal pessaries, and it is also present in the form of a gel and also in the form of a parenteral form. Parenteral form in the sense IV route. So in our India, we don't use IV route, but we will use it dinoprostone gel most commonly. So in the form of vaginal tablet and pessaries in India, no, we don't use it. So if we are using in the form of a tablets, we'll go with the 3 mg of the dosage, which we have to keep it behind inside the posterior fornix, and every 6 to 8 hours you can repeat the dosage. So maximum you can keep it till 6 mg. That means you can use 2 tablets with an interval of 6 to 8 hours. Whereas the vaginal pessary, whenever you are using, there will be this vaginal pessary, you have to check the diagram. Sometimes if you are a DNB student, they will ask you the dinoprostone vaginal pessary diagram, they will show, and they will ask you when is it used. Okay, so if you are whenever you get a time, just go through this slide, vaginal pessary dinoprostone, which is consisting of 10 mg. It will work for 24 hours, and when the cervical ripening is adequate, you can remove it. And when it comes to the dinoprostone gel, you are keeping 0.5 mg in the cervical canal, or it can be used in the posterior fornix as well of 1 to 2 mg. But mostly the action will be good if it is kept into the cervical canal, that is then the action will be very good. As of like whatever the practical I have done, I have seen a good results when it is kept in the cervical canal compared to the posterior fornix. Parenterally we don't use in India, so you can skip this. But if the examiner asks, it is better to remember that 1 mg per ml you can give it through IV. Carboprost, yes, we use it in the clinical practice as well. What is this carboprost? It is a prostaglandin F2 alpha. So whenever you are answering, you have to answer like this. It is a prostaglandin F2 alpha, so which is acting on the smooth muscles, and it will cause its stimulation. So it is particularly used at the time of this PPH, uterine atony, when the oxytocin and ergometrin is unresponsive. So It is used in the treatment of PPH. Up to 50 microgram per ml can be used in IM route. So it is used every 15 to 90 minutes, maximum of 8 doses we can use. The only route that we can use the carboprost is IM route. No IV route. You should never answer IV route. That's a blunder. And every 15 to 90 minutes you can repeat the doses, maximum of 8 doses. Side effects of this prostaglandins is, before giving this injection, better ask your patient about any cough or COPD issues or any asthmatic issues, because it will cause the bronchospasm, and also systemic hypertension if they have very severe hypertension, and also it will result in the pulmonary edema and cardiovascular collapse also is reported in some cases. So better to avoid in asthma cases and hypertensive cases. Misoprostol. Misoprostol, it is a prostaglandin E1 methyl ester. And where do we use this misoprostol is that we will use either immediate after the delivery, or after at the time of abortions for MTP kit, and also immediate after the abortions if there is still any RPOCs there, we can use this misoprostol. So it will actually rapidly absorbs into the circulation, and it will affect for the induction of labor and also for the cervical ripening. Initially they were used to use this medication for the peptic ulcer disease as well, but I have never seen using for peptic ulcer disease. Transvaginal route you can use, buccal route you can use, sublingual route you can use, rectal use also you can use it. So it depends on which route you are giving this. Based on that, the dosages can be given. In cases of the after following the delivery, we can give up to 600 to 800 micrograms you can give. So, or for the induction of labor and all, you can use 25 to 50 microgram every 3 to 6 hourly, either by the oral route or by the vaginal route you can use. When you are giving it through the sublingual or a buccal route, you are using it for the induction of the labor, and at the same time when there is a good cervical ripening has been happened, you can use it along with an oxytocin if needed. So in which cases it is used? One is induction of labor, second is for the termination of molar pregnancies, and cervical ripening. So in obstetric cases we are using it for the cervical ripening. In gynec cases we do use this misoprostol in the D&C cases. Priorly we keep these tablets 3 hours before the procedure. If we keep this misoprostol in the vagina, then it will ripen the cervix and it will be easy for us to do the D&C procedures in the gynec cases. So, and also in the obstetric cases it is used for the induction of the labor and augmentation of the labor, and it is also used for the management of the atonic PPH. Advantages of misoprostol is it is cheaply available in the market, and it can be stored at the room temperature, and it has a long shelf life. You can also self-administer this drug either orally, vaginally or rectal use. There are very less side effects, but when you induce it for the delivery, the interval is very short and it needs an oxytocin for the augmentation of the labor. Failure of induction is very less. Contraindication: if the person is hypersensitive to this drug, better to avoid in such cases, and if they have any previous history of any cesarean scar, then better to avoid this drug. And also the prostaglandin E2 also we have to avoid in cases of the uterine scar. and also in the hypersensitivity to this drug, we have to avoid this drug. So this is contraindicated in cases of the active cardiac diseases or pulmonary diseases, renal or the hepatic diseases, and also in the hypertension cases. Any cardiac, any pulmonary or any renal, any hepatic disease and hypertension, better avoid this prostaglandin derivatives. And particularly whenever we are giving this drug, we have to ask about the asthma history, we have to ask about the glaucoma history, we should also ask about any glaucoma histories, and also renal and hepatic dysfunctional histories. And if there is any previous history of bronchial asthma or hypertension or COPD is there, better to avoid this drug. So, as we have read in the two classes about the oxytocin drugs, about the ergotative derivatives and the prostaglandin derivatives, the oxytocin dosage I have discussed. You can use it 10 to 40 units in 1 liter of saline. In the normal saline you can use, or in the ringer lactate. If you are giving an IM, you have to give it at 10 units. And we need to avoid diluting and also the rapid infusion of IV bolus, because it will result in the hypotension, and the side effect of this oxytocin toxicity is water intoxication. And methyl ergometrin 0.2 mg you can repeat every 15 minutes, maximum of 5 doses you can give, and you have to avoid in cases of the hypertension and also in the cardiac diseases. Carboprost you can give it as a 250 micrograms. IM injection you can give every 15 to 90 minutes, you have to repeat of maximum of 8 doses. Better to avoid in asthmatic patients, and also if there is any major organ diseases are there, better to avoid it. And misoprostol, it is also available in the market as a cytotec tablets, which can be used rectally as a 800 to 1000 mcg rectally we can use it post delivery.